Good evening from Kuala Lumpur. My name is Pascale Allotey, Director of the United Nations University International Institute for Global Health, UNU-IIGH, the UN designated think tank on global health, hosted by the government of Malaysia at the National University of Malaysia, UKM. On behalf of the Lancet Commission on Gender and Global Health and the UNU-IIGH Gender and Health Hub, I'm delighted to welcome you to this event in conversation with Nina Schwalbe. Nina is a commissioner with the Lancet Commission on Gender and Global Health, and in that capacity, she is leading this conversation, drawing on years of experience in the area of vaccines through UNICEF, Gavi, and several other global health initiatives and institutions. The Commission aims to respond to the pressing need for substantial structural and system-wide change towards gender equality and health equity. So from the perspective of the Commission, this conversation provides an opportunity for us to do a deep dive into a critical area of global health with 6 amazing women who bring a good dose of reality into the challenges, potential solutions, and good practice in an area that is bereft of gender considerations. And from the perspective of the Gender and Health Hub, the outcomes of this discussion will further inform strategic directions and the production of analyses and evidence in collaboration with our partners across UN health implementing agencies, the funding and academic communities, government, civil society, and activist organizations, essentially all of you. We hope that after spending the next 90 minutes with us, you leave stimulated and inspired to push harder and further in your work towards achieving equity and social justice with the goal of health for all. To that end, get your fingers walking and talking and tell us where you're from. Engage with the panel with your questions, regardless of the platform that you're using. Live tweet and enjoy the conversation. We will be spending the next hour and a half with Nina Schwalbe, previously introduced, who's based in New York, in New York City. Akosua Sika Aisi, who is the Deputy Director for Public Health for the Greater Accra Regional Health Directorate, Ghana Health Service, joining us from Accra, Ghana. Jamille, Bigio, the Senior Coordinator for Gender Equality and Women's Empowerment at USAID, calling in from Washington, D.C. Fiona Atuhebwe, who is a new vaccines introduction officer with the World Health Organization office, Afro office in Brazzaville, Congo. Mira, Johri, who is professor at the Department of Health Management, Evaluation and Policy at the School of Public Health, University of Montreal in Canada. And Sarah Golding, Assistant Director and Principal Specialist in Gender Equality at the Department of Foreign Affairs and Trade, joining us at a rather ungodly hour from Canberra, Australia. Thank you, Sarah, for that. And I already have the first provocative question, even before we start, about why we have a panel of only women. You may recall that I highlighted in the beginning that in spite of some evidence of disparities in access to vaccines, particularly impacting women, this is an area that has not been prioritized in mainstream health service delivery and vaccine development. Indeed, some of our male colleagues in vaccines have noted that sex and gender are not priorities in this space. We have a panel who have the experience to demonstrate otherwise. I invite you to listen, to engage, to challenge, and enjoy the discussion. And with that, I would like to cede the virtual floor to Nina, who will provide a brief presentation to set the scene. Nina, over to you.
Great. Good morning. Thanks so much, and good afternoon and good evening. Is the sound okay, Pascale? Yes, I'm going to assume that's a yes. Great. So thanks so much for the opportunity to lead this conversation on behalf of the Lancet Commission, IIGH, and the Gender and Health Hub. I'd like to thank Vidisha, Tiffany, and Anne, who are the engines behind this series, as well as my fellow Lancet commissioners, Pascale, and colleagues at UNU-IIGH. In the next few minutes, I'm going to set the stage for the panel discussion by highlighting some of the data and evidence on gender and vaccination. Many of these slides are based on an analysis I did while at USAID, where I served as the Director of Vaccine Access and Delivery, setting up and managing the Biden administration's donation of 1 billion vaccines to COVAX. So thank you as well to colleagues at USAID. You will recognize some of your work in these slides. Well, there is a lot to say on gender as it affects the entire vaccine value chain, starting with production and design. Today, we're really going to focus on delivery. So with that, to start, I want to go over a few definitions. Whereas sex refers to different biological and physiological characteristics, gender refers to socially constructed characteristics. Today, we'll talk about both. Data and graphs can be deceiving. In some countries, in early days, supply constraints and decisions about who got prioritized first affected whether more men or more women were vaccinated. I've given a few examples on this slide. When there is adequate supply, we would expect to see numbers more reflective of a country's population structure. More than a year after vaccines were made available to most countries, we turned to WHO's website to see what we could find on whether men and women were being vaccinated equally. But hold the press. Digging into the data sets, we realized that some of the sex data in their COVID-19 dashboard are nearly a year out of date and really have no relation to where countries are today. So taking the data, you also have to use the denominator to understand whether the coverage data listed in the WHO website are the same as the coverage data reflective of today's data. And that's a problem, a very serious problem. My colleague Laith and I spent days trying to figure out who's reporting what and where, and we came to one strong conclusion. The data are flawed, inadequate, and outdated. We're hopeful that someone listening on this call can prove us wrong, but here's what we found. The countries in a color are those that have ever reported data, disaggregated data, sex disaggregated data, either to WHO or on their own country websites. When we looked at February specifically, we saw that of the total number of countries providing data to WHO, only 56 of those were providing sex disaggregated data. So they are providing data, they're just not providing sex disaggregated data. Despite binding commitments by the UN and requirements by COVAX, sex disaggregated data on vaccines are simply not being reported by countries regularly, consistently, or in real time. So let's go back to what we know. While disaggregated data are critically important, understanding gender barriers goes well beyond sex and numbers. More broadly, among other effects, this analysis published in the Lancet in March shows that women were more likely to report loss of income, drop out of school, and experience violence. Now, turning to immunization, this slide comes from an analysis we did while I was at USAID. It shows what we knew coming into this pandemic about why gender matters in vaccination programs more broadly. Gender-related barriers in access to services include literacy and education gaps, work and domestic care obligations, limited mobility, and lack of decision-making power in the household. And they are as true, as we found out in COVID, in low-income countries as they are in high-income countries. The issues here strongly map to the current delivery challenges for COVID-19 vaccines. The evidence on this slide are again based on analysis we did at USAID, including a survey with countries. As with other vaccines given to women, like tetanus or HPV, there were some concerns about fertility and side effects. Of interest on side effects, in a study we did here in New York City, this concern was more about the person and whether they would have to take time off work or need help with childcare than it was a fear of they themselves getting sick. Messaging was confusing, and overall health-seeking behavior was also low, primarily because of lockdown measures. While these are tough problems, they are not insurmountable. The studies on the left are just to show we already know a lot about the barriers, and we know a lot about approaches that work. So in the next 90 minutes, we'll dig deeper, but here are a few thoughts to tick us off. Again, borrowing from slides we developed at USAID. Data, data, data. People talk about measles outbreaks as a canary in the coal mine for vaccine-preventable diseases. Perhaps gender data are the canary in the coal mine for data on social determinants of health. If we can't get basic sex disaggregated data reported regularly, the outlook for measuring other determinants is bleak. In terms of data, we know they exist. Countries use electronic reporting forms like DHIS2 and are required to report to WHO through the electronic monthly reporting system called the EJRF. But clearly, they're not making it through the chain. And as we saw in the previous slide, we have countries that are reporting data. They're just not reporting sex disaggregated data. So we need to advocate to change that as a non-negotiable condition. In terms of access, we need to continue to bang the gender drum loudly and repeatedly so that every public health strategy is underpinned by a consideration of gender and other social determinants. And again, as with every other area of public health, we need to engage affected communities in the process of co-designing interventions and work with and for them, that work for them. In closing, I want to give a shout out to this tool developed by a group of UN partners under the leadership of IIGH and the Gender Hub. It's a simple step-by-step checklist, which gives concrete actions for planning for and addressing gender-related barriers at each stage in the vaccine value chain. In thinking today about what the counterfactual would have been had we used it systematically, the sad fact is that we can't really know without robust, real-time, disaggregated data. But on the face of what we do know, my hypothesis would be that it would have made a difference. Given the billions of dollars spent in response to COVID, if we don't come out of this pandemic with a better data system that allow real-time reporting of sex disaggregated data at a minimum, we have failed. That said, we can use the evidence we have to double down on gender programming as a cornerstone of an equitable response. Thank you.
Thank you so much, Nina, for that, for just being able to highlight very clearly what some of the issues are. I'm happy to open up for other questions from the rest of the panel for now, just for this short bit. But can you, the message is really clear, the problems with the data. So what would you say needs to be done about it? Is it an issue of quality? Is it an issue of access? Is it an issue of negligence, do you think?
Yeah, great question, Pascale. I think it's all of the above. And I think that as with other interventions in public health, we probably need both a push and a pull strategy. And what I mean by that is that on the country level, we need to invest in systems. We really need to move to digital. COVID is an opportunity. We've all in Malaysia, they developed a digital app where everybody was checking in everywhere with their COVID status. I mean, we've really jumped a digital divide. And that needs to apply to regular health systems data. So on that end, there's a so-called push to invest in country level systems. But we also need a sort of a pull incentive. And that means gender disaggregated data, sex disaggregated data, it should just be a matter of policy. It shouldn't be a question. Countries should be required to report it. It's already a WHO requirement. It's actually part of CEDA. It's a UN requirement. So it's time to put a little teeth into the reporting of that. And that includes making it a mandatory requirement for countries. Full stop.
But ultimately, this in some ways, the incentive is required, right? I mean, there is we need to see that there's a problem for this to create the push factor. So, and I noted from your intro that you have had experience. You've worked. You're an expert and have had extensive experience working with institutions like Gavi. How was the gender strategy there developed? And if you have institutions that have a strong gender policy, surely this shouldn't necessarily be an issue.
I mean, I think at Gavi, and Gavi was actually quite recently put out as an organization by Gender 50/50 that had done well on its gender policy. When we introduced that policy it was either 2010 or 2011, we got a lot of pushback, tremendous pushback. We were told there were no gender barriers to health. Men and women were getting, boys and girls, because most of the early vaccine data are really about childhood immunization. COVID is the first time we've had a universal adult vaccine. But we got a ton of pushback. Boys and girls were being vaccinated equally and not looking at those more gender barriers and access to care. But we did set some targets. We said every committee had to be 50% women. We said the board had to be 50% women. And it did make a difference. People paid attention and they had to comply. And at USAID, we also had a very interesting discussion there about the extent to which you could require data. So could we ask COVAX, or could we suggest to a mechanism like COVAX that gender disaggregated data was a requirement or a condition of aid? And it was an interesting discussion that came out of that. One of which was to say that you can't make it if you need to give people help along the way if they're not doing it. So if you're going to make it conditional, you have to set a deadline in the future that allows countries to get up to that point whereby they can meet the deadline. And that's why I talk about both push and pull. So the pull is it's a condition. The push is you give it the support that it needs to meet that condition.
And at the moment, in terms of accountability of global health institutions to gender and to collecting data, even within both institutionally and in the programmatic work that they do, it's not clear what the accountability mechanisms are and how to push them through. Any thoughts on how we can put a bit more teeth into getting this change happening?
I am surprised at how many hours I spent on the WHO database trying to figure out why, if a country had reported data, it hadn't reported sex disaggregated, and why some countries had reported sex disaggregated in September and more recently reported in February. So I think the WHA has some responsibility here, and it is a question that really needs to be taken up by the WHO. Why, despite repeated calls over now decades for sex disaggregated data, is not happening? So I, not being a member state or representing one, would definitely ask the member states to really sort of double down on why, despite the fact that they've said this is a critical for decision making, for programming, and for equity, aren't making it a hard and fast requirement.
Fantastic. Thank you very much. I want to close this initial section. Nina, thank you very much for kind of really putting the issues out there that we're going to now explore into much greater detail with the panel, and also to get some really concrete examples. Ladies and gentlemen in the audience, please continue to send comments and questions so that we can engage the panel over the next hour and a bit. We will also make sure that references that are made to various documents are made available through the comment section so that you can have access to them. Now, in this second section of the conversation, I will hand over to Nina to moderate the discussion with the rest of the panelists. Nina, over to you again.
Great. Thank you, Pascale. So we're going to split this section into three. We have three different sections of the discussion. We're going to talk about data, we're going to talk about barriers and enablers, and we're going to talk about solutions forward. And in the middle of that, we'll have a specific Q&A. So please keep your questions coming in, and we will moderate those moving forward. So the first question I'm going to ask is to Akuswa. Tell us a little bit about how you use data to inform your work in Ghana.
Thank you very much, Nina, for the presentation. And as you rightly said, data is the starting point of the gender discussion. And as a country, we invested in an electronic database system to provide real-time data, which also gives us access to gender disaggregated data so that we can use it to inform our day-to-day operations and then be able to address real-time issues as it comes up with the vaccination. So our electronic database helps us capture both data on the demand side and the supply side, and that's holistically analyzed to give us a very good perspective to be able to make very good gender-informed decisions in the delivery process. Beyond the electronic database, routine research is also constantly being done, which also provides some gender disaggregated information that is helpful for implementation. So I'll share two quick examples. The first one that happened prior to the implementation of the entire vaccine rollout. So prior to its implementation, a lot of research was done to find out what the perspectives were on the ground and whether people would even accept the vaccine. And one key study done by Al-Hassan et al. To see health work was done amongst health workers to find out their willingness to take up the COVID-19 vaccine and also willingness to participate in clinical trials. And since health workers, the bulk of them, those in Ghana, about 60% are female, it was a good study to help us to see acceptability amongst the people who are actually implementing the process. And that study found out that females were 10 times, amongst those who were unwilling to take vaccines, females were 11 times more likely not to accept a COVID vaccine if offered as compared to males, and also 10 times less likely to offer a vaccine to someone who needed it. And this finding was quite interesting because it meant that the people that were going to deploy the vaccines weren't ready to and didn't have the needed knowledge to be able to support the process. And from the study showed that the unwillingness was mainly due to fears, health and safety concerns, and some religious and cultural norms. So findings such as this and other studies informed a very aggressive risk communication campaign aimed at the health workers, and this was very crucial to engage them and get them to understand and have an informed knowledge about the whole process so that they can be partakers of the entire deployment. And thankfully now we can say in the last survey that as a country, 90% of our health workers, the bulk being women, have now had at least one now had their first shot of the COVID vaccine, and also 70% of them are fully vaccinated. So constantly, data drives our innovations and our interventions, and because it's real time, it helps us to address current issues. Another scenario was when the vaccination process started, and initially you would review the coverage, as you said. I'm sure you were relating to the fact that sometimes the data is very late, but because our data is real time, we're able to review constantly and then address the issues as it comes. So reviewing our data in the initial phase showed very comparable coverages between males and females, between 49% to 51%, but doing a very good gender analysis and intersectional analysis showed that it was very skewed towards those who lived in the urban sector as compared to those in the rural, about 62 to 38, and then also was skewed towards women in the formal sector. So our vaccine deployment was phased, and initially we prioritized health workers and those in the essential worker group, so security agents and other formal workforce. And once we scaled up, however, we were still leaving behind the women in the informal sector. So then reviewing the data consistently and then using the data to start the gender analysis process through stakeholder engagement, focus group discussion, key informant interviews, we realized that most of the people were being left behind because of our deployment strategies. And our strategies at that time were mainly statics in the various public hospitals or designated community centers, and people would have to go there and queue or book an appointment for the service. But for the woman that is taking care of children at home, the woman in the market trying to make ends meet, she couldn't have the time to go out there and join the long queues and struggle to get a vaccine. And in one of the engagements, I remember vividly the regional lead of the market women saying, and I quote, that bring the vaccines to us in the markets, bring them to our homes, and we'll make sure that our people take it up, would convince our relatives and our friends to come on board. So that spiraled a new approach through extensive engagement, spiraled a new deployment approach, which was the home-to-home, house-to-house market approach. So then health workers had to leave the comfort of their working space, and we had to reorganize and look at the entire logistic implications of moving vaccines beyond the health facilities and going home to home, house to house to be able to reach. And then as we did that, we also used data to inform the successes and also guide the implementation. So areas where it wasn't working based on uptake on a real time, we use the data to revise our strategies so that collectively we're able to reach all women, all men, all children, adolescents, all adults, all people of the entire spectrum with timely vaccines, ensuring that we leave no one behind. And the process is still ongoing. Thank you.
Thank you, because that's incredibly inspirational. Tons of questions for you, but let's have another intervention before we come back. Jamille. Put her up. Hi, good morning. COVID-19 has exposed, as we just heard from Akusawa, actually where they have it or actually have data and are using it, but overall globally, the paucity of gender disaggregated data. What do you think it will make to take gender disaggregated data a norm in practice and policy, as we've just seen in that example from Ghana?
That was a powerful example from Ghana, and so inspiring to hear it, and certainly something that we are hoping to see in other countries, and something that USAID is working to support in other countries, to have that kind of standard of practice that the data is collected and then it is analyzed, the gaps are identified of where there are inequities and disparities in vaccination access, and programs are adapted to adjust and to close those gaps. So that's the kind of model certainly that we want to see elsewhere. And I think there's a few different steps to take to support that. So first, Nina, you'd mentioned the importance of what's happening at the global level with WHO and UNICEF and other UN agencies that are focused on vaccination and vaccination data. So there it's critical that one, that they have and put forth internationally recognized indicators of gender equity in vaccination. So that's something that we see WHO and UNICEF doing more to do so, and then to actually support the integration of those indicators into routine health information systems, relevant coverage surveys. So this kind of data is imperative to ensure evidence-based programming and responsiveness to the pandemic and to track equity in vaccine implementation. You spoke of the importance of WHO, for example, then also encouraging countries to ensure that they are using and reporting on these indicators, and that we have that data consistently to be able to track over time. So that is certainly one key piece to this this reform. The second area is looking at what are the challenges for countries in tracking tracking sex disaggregated data and being able to report it in a timely fashion. So here we know that in some countries there are data backlogs where paper records, for example, pile up at a facility before they're entered into a national database. So that presents a challenge in providing timely and accurate patient-level coverage data. We also know that there are challenges with digital tools that we can help, collectively help to solve to help enable real-time reporting. That's something USAID is providing technical assistance around to help ministries of health meet their data needs. So in countries around the world, we've been doing work to provide training and surge support for data clerks to unclog backlogs and to put in place new systems to support Ministry of Health digital health teams. There's also space for donors collectively, certainly, to do more to support central digital solutions that can be rolled out across countries to help improve data collection functionality. And bottom line there is we want the global level system of having the data, having the best practice guidance of what data should be collected and sending that signal. And then at country level, having the data systems in place to collect that data, as we heard in the case of Ghana. And that's all critical to be on the measurement side, to be monitoring, analyzing vaccination coverage, doses administered, broken down by sex. We also know it's important that our assessments, both quantitative and qualitative, are actively seeking and identifying gender-related barriers. One example of this that has been helpful in the COVID-19 space is Johns Hopkins COVID-19 Behaviors Dashboard. So this is a tool that has data from a global survey on knowledge, attitudes, and practices around COVID-19 disease and vaccines. And it found gender differences in vaccine confidence and uptake in many countries, which in turn has enabled more tailored interventions to promote vaccine demand. So we want to ensure, that's a global tool. There's national assessments as well, looking at understanding, okay, we see if there are gender inequities in vaccine access, then the assessments to understand why that is, to be able to then inform programming and policy and advocacy. So that's where you can have, ensuring counterparts at national, subnational levels understand why there are gender barriers to vaccines and understand how to reduce them to help reach missed communities. We heard examples from Ghana on that, of understanding the need to now shift into marketplaces or have different strategies of where to provide the vaccines in order to better reach women with them. There's also lessons that can be drawn certainly from other health areas where there's been work to address gender barriers in accessing health services that can inform the vaccine programming, immunization programming, depending on what the gaps are that are identified. And that's something as well that USAID is supporting around the world. In a similar example to what we've heard from in Ghana, in Kenya, USAID supported a routine immunization transformation and equity project that supported local health officials to understand and address why more COVID-19 doses were being administered to men than women. Some of that was looking at vaccination sites, shifting it to marketplaces and churches that were more accessible, more frequented by women. And by taking that step, doing an intervention like that, Kenya was able to increase the number of doses that were being administered to women, and were able to close that gap. So what we hear, again, the global level effort, investing in the national databases, and then supporting the interventions informed by those data gaps to actually close that data. And then let's keep the support to keep reporting so we can track that over time and identify where gaps may be in access to vaccines. Over.
Great, thank you so much. I'm going to bring the panel up for perfect. Fiona, Mira, and Sarah, who should come up eventually. Reactions or questions around what you've just heard? Mira, go ahead, please.
I want to say that it's really inspiring to hear Akosua and what's happening in Ghana. It's one of the best examples that I've seen of really making use of data in almost real time to make more equitable policy.
Fiona, do you want to comment or question for either Jamille or Akosua?
Hi, thank you very much. Thank you very much, Nina. This was excellent information, especially for us who work on the ground and closer to the countries. I know Akosua is much more into the depth of things, but the decision to move services closer to the people is something that has changed our coverage much, as we're still very low in the African region. But using that data to see that static sites were not giving us what was required, especially in adult populations, and more so women, like she mentioned, that usually work out of home, but also in very informal sectors that do not have proper timing to help them to access services. So the use of that data to make decisions and on deciding on strategies on how to reach the women who are being left behind is excellent. Thank you.
Sarah, comments?
Yeah, look, it's apologies for the choppy internet in Australia, but I guess what I just wanted to flag is I think that these issues that we're talking about with gender data and immunisation are issues that we see around gender data writ large. And one of the real challenges that we have when we're talking about gender data and immunisation is that we've had a history where when you've looked at childhood immunisation in particular, that you haven't seen a big difference in the number of girls and boys that have been immunised. And so it sort of felt a bit like for a long time that gender hasn't really mattered. Because lots of girls, lots of baby girls and lots of baby boys were both getting immunised. But it's when you start looking at different age cohorts, but also when you start looking at the communities that aren't being reached by basic immunisation and primary healthcare services, where you have compounding inequalities, that you start seeing a gendered difference. And that's around who feels comfortable coming to the clinic, who's able to come to the clinic at different times. And then you look at other questions around, which girls and which boys are being reached by immunisation services, and are they children with disabilities? And so I think it's that intersectional element where you want to ask yourself, there's been this myth that gender doesn't matter to routine immunisation, but in fact, it's actually absolutely critical when you're talking about immunisation in a more complex context or with harder to reach communities. And the thing I wanted to note is that we often see people want to do analysis around gender data and use female-headed households as a point of understanding where economic diversity or differentiation really hits home. And that's true. That's very, very true. But what we don't do is we don't ask questions about what's happening within the household. We don't use data that actually cracks open the household and asks about the gender differences and dynamics for older women, older men, younger women, younger boys, and what that means in terms of access to resources, access to information, access to opportunities. And so I think that there is a learning for us there about really asking ourselves the hard questions around who has access to information, and challenging ourselves with what we have thought was the true from a first blush at data. And as you're really encouraging us to, Nina, as Jamille and as Akosua has highlighted so powerfully with how she's worked in Ghana, to ask ourselves questions and look harder at the data to see what more it can tell us if we ask different questions about whose perspectives are we hearing from here, and try and crack open the household and ask questions around inequalities within the household. We know they're there, but we don't have the data. So gender data is something that's so critical for decision making, but we often don't interrogate the numbers enough to realise exactly what stories we're hearing and what we're not. Over.
Great, thank you. So I'm going to ask Akosua and Jamille to give some thoughts, and then that's a really good segue into our next discussion. So Akosua, yeah, please, some reactions.
Thank you very much, Nina. So as just as everybody has said, gender disaggregated data is very helpful at all levels. And I'm sure we'll get into it, but it's important that it's planned for, as we've been talking about, it's planned for right from the policy table. So at the agenda setting table, we need to make gender disaggregated data a priority right from then, because what is also not planned for and set in legislature cannot be planned, cannot be budgeted for, and therefore would not have the resources to implement it. So then technically, we needed to run across right from the beginning of the entire process, and then it will cascade down to the implementation level. So it's key that we programmatically look at it, and all health partners from the global level need to make a conscious effort to make sure that it's integrated into routine systems. Then it can be scaled down to the national and subnational level. Thank you.
Great. Jamille?
Thank you. And I agree, and it's important to recognize that the pattern that we've just talked about with COVID-19 is one that applies, it, as Sarah noted, in other areas with gender data. We know that there is not enough investment in gender data across data systems. We know that what we don't measure, we don't count. What we don't understand, we can't shape policies and programs to respond to it. So it is critical that both here, when it comes to vaccination data, COVID-19 specifically vaccination data more broadly, and truly across our data systems, that we have routine practices of, as a minimum baseline, collecting sex or gender disaggregated data as a first step, let alone looking at different indicators specific to the experiences of women and girls. So this is a broader lesson for us to continue to be reinforcing in national statistical systems and other data systems, to ensure that it is standard practice across the board to, as I said, at a minimum, collect sex or gender disaggregated data, and then to build from there. The other piece to note is, as we talk about the barriers in terms of, as we talk about the gender inequities in access to COVID-19 vaccines, and the kinds of patterns we saw around that, those are certainly ones that we see both in other vaccine situations. There are differences certainly that have been increased because of how the COVID-19 vaccinations were rolled out, how quickly, where they were tested with pregnant women, for example. There's more gaps for misinformation to spread, but still the patterns we saw are ones that we see elsewhere. And so this is an area where it's important to note at the outset that we have lessons we can draw from other pandemics, from other immunization campaigns that can inform the work that we're doing around the COVID-19 vaccinations from the outset. And so that is another piece of this, that we both should be ensuring it's standard practice to have sex disaggregated data, and be drawing lessons from other places as we wait to have that data, to be able to anticipate and recognize where there may be gaps, where there may be challenges. Over.
All right. So moving from, thank you. And we'll come back to data throughout this, because data are so critical to informing decision-making, but so is other types of evidence. So moving to shift to talk about barriers, enablers. Mira, in your research on routine immunization, which has been referenced by the other panelists, with the benefit of hindsight, what would you have predicted as the barriers and enablers, and what are the key takeaways?
Thank you so much, Nina. I prepared something in advance, and then I just feel that the panel has been so amazingly clear that I'm going to cut it short a little bit and get straight to the point, which is, I think we have learned a lot over the last couple of decades about how gender and other very important social determinants structure access to services such as immunization for women and children. And as Sarah raised, I think the data sometimes don't get interpreted. So I think we need to challenge ourselves to look at, we know, for example, that women who have the sixth child, the seventh child, that the sixth and seventh child is less likely to be immunized. We don't tend to think about that from a gender lens, what it means to be a woman who's having the sixth and seventh child, how much control over reproduction that implies. When we look at data, we see that the combination of zero education women and zero education men is particularly correlated with lack of access to all kinds of services. We don't think about what it means for the gender norms that those women and men are facing in that particularly constrained social role. We tend to think about things as, you know, poverty or physical access to services, and those are very, very important factors. But there are also very gendered access to services that are implied by these things. So basically, I would say that over a 25-year period, we've come to realize that the social norms, values, and beliefs that shape gender and other forms of access imply restricted agency through lower education, through lower access to labor markets, to lower financial resources, lower decision-making power within families, family dynamics, and that those things are extremely relevant for access to all kinds of services, immunization, and certainly routine, and certainly also COVID-19. So if we challenge ourselves to say, what did we know? I think we knew a lot. And why did we not know it in time for COVID-19 in a lot of places? I think that comes back to a we that Nina, you raised right from the beginning, which is a question about who is sitting at the table. Is that group sufficiently diversified? And I think a lot of the time, the we in decision-making power, and especially in the COVID-19 situation, the high up Ministry of Health we has often been a pretty limited group of we. It's been often very male. It's been often a very privileged group in many respects, and we haven't thought through the evidence perhaps as we should have. If we look at what we could have done differently, so in the place where I work and feel most affiliated to, India, I would have to say some of the most progressive strategies that India took for using a digital-first approach for immunization and vaccine access, for example, were also strategies that were exclusive of certain groups. Groups, obviously, who are poorer, who have less digital access, who have less digital comfort, and women are systematically part of those groups. Not all women, of course, but many, many women. If we look, for example, at the risk of misinformation and distrust are particularly easy to spread when people have less access to trusted information sources and less pre-existing knowledge. So I think, again, we could have known, we did know that certain groups were specifically likely to be susceptible to receiving wrong messages and to building distrust. And we took a long time to work on that information and to try and counteract it. And when we look at the whole, I think we know that women's health is deprioritized by women themselves, by their families, and in general. So we need proactive strategies of the kind that we've been hearing about how to take those services to women proactively to counteract the forces that deprioritize in the first place. So I think I will stop there and pass the honor on.
Thank you, Mira. Fiona, turning to you, really the same question as to Mira. In your research and work on routine and with the benefit of hindsight, what would you have predicted and what would you have done differently?
Thank you very much, Nina, and my responses are not so far from Mira's. So one of the things that stood out with this COVID vaccine, with all the infodemic it came with and all the issues that were there before even the vaccine came out, unlike other vaccines, was the fact that we did not have evidence or data on the vaccine effectiveness or the safety in pregnant women and lactating women. This did not happen right at the start. The vaccine already came with a lot of rumors surrounding it, but the fact that we did not have this information right from the start was a problem. We have data that shows that women have specific questions and concerns about the vaccine. And if these are not answered, they are a deterrent for them getting the vaccine. In Africa especially, we have a young population. Most of the women are women of childbearing age. And on the decision-making level, again, this is Africa, majorly the man, the head of the household, makes the decision. And we found that men are okay to make the decision to get vaccinated, but they still have an issue with the continuity of their lineage and still have an issue with is actually this vaccine safe for my wife? Is it safe for, if my wife takes it, shall we have children? The fertility issues that were talked about. But then we also had the issue of, yes, the vaccine came and with a few doses, especially on our continent, and we had to prioritize. We had the highest priority groups. Of these were the healthcare workers. One of the groups was the healthcare workers. Majorly, the healthcare workers in Africa will be women. The nurses, the midwives are majorly women. It's doctors that we find that are men. So if we had put a gender lens to understand the concerns that these women had, we have healthcare workers really also had an issue with this vaccine. We took it for granted that because they're healthcare workers, they understood the vaccine, but we did not put into context the fact that they are also human beings that had access to the infodemic and the wrong information, the misinformation, and needed more information about this vaccine. But the fact that most of them are women, we also needed to have applied that gender lens to understand the concerns, why healthcare workers, for example, were not taking the vaccine, to change our strategies. Again, the delivery strategies have been talked about. Women in Africa, especially those in low income and emergency settings, conflict areas, will deprioritize their health and prioritize health of their families, of their children, and of their husbands. So for those women, we were in a pandemic, we had lockdowns, we had loss of employment, like you mentioned at the beginning. So there were lots of issues. So these women generally also deprioritized themselves and prioritized other people's health. So we had to also have to think of that gender lens, but also that the limited control over the money, over lives, over their own lives, over their time, over the information they get. It makes it difficult for women to access these services. And I think it was great to see that the data that informed the Ghana change of strategy and several other countries in the African region comes from that fact that women will not afford, they don't have the transport, they don't have the means and the time to come to the health facility to get this vaccine. So the closer we get the services to the people, the easier. So, and it also generally affects women. So I would like to stop there for time purposes.
Thank you. I have a question actually for you, Fiona, which is a lot of what you mentioned isn't different from other new vaccines introductions that you also work on. So why did we have to have an aha moment around COVID? What happened that those learnings that Sarah also mentioned weren't kind of incorporated from, and Mira as well, from the get-go? And maybe that question also to you, Mira.
Thanks for that question. So we realize that women, as I mentioned, do prioritize the health of their children, their babies. Whatever you tell them, sleep under a mosquito net, give them boiled drinking water, the woman will give the child boiled drinking water. She will not drink boiled water. So this generally, as a mother, as a parent, the prioritization of children and the childhood illnesses goes beyond the woman herself. But this time around, it was the woman herself that needed to be protected. And they do deprioritize their lives. So if it was for the protection of their child, we know that many actually did not come to the health facilities because of fear of getting COVID and transmitting it to their children. So this was, when it comes to them, they treat themselves differently. But if their child was sick, they managed to find a way of masking up and taking their child to seek treatment, but not themselves to seek treatment. And we saw how those disparities worked. So this time around, it was because it was the adult women themselves. Even much as we talk of gender and forget about the men also had their own concerns, but they normally seem to take risks higher. But this time, because it was not children, where the caretakers are so concerned about them, the caretakers had to be concerned about themselves, which is the question of who cares for the caretaker. This time around, they needed to be the carer for themselves.
Mira or other panelists, do you want to comment on this?
Thank you. I want to say that I completely agree, and just to also reinforce the message that many of the people who were in the position to make decisions on policy early on were men, and they were probably not thinking of this first. So I think that's another complementary factor.
Comments from other panelists. Akuswa, why did we not take lessons we knew?
I think that with COVID vaccine, especially because the disease was new, was an unknown virus, and most people it caused a lot of fear and panic. So when you are dealing with an unknown virus and now there's a vaccine for something you already don't know for. So for us, we had to actually show community members in our communication approaches the benefits of vaccines over the years for them to have that confidence. This one we do not know, but now in our time, we have a vaccine to deal with it. Those who were addressing smallpox in their time, and would show you a picture of a kid with smallpox, and you'd realize that in their time, those were the issues. And you'd see these pictures, and now we do not have that randomly happening in our time again. It was because of the benefits of vaccines. So we worked, for us as a country, we worked from what is known to the unknown. We showed pictures of children that had polio. And in the past, you remember that only every school or every home probably had a child who had an infection with polio. That we don't see randomly again. So it's important that we work, and we, at least on the operational level, we work from what is known to the unknown, and we use that to address their fears and concerns, because everybody would definitely have some concerns about things that they have never experienced before or never known. And then picking up from where Fiona left off with the pregnant women vaccination, as a country, we introduced that just in January. And it's interesting to know that for we've been saying since implementation in March 2021 that our pregnant women were not eligible because the evidence at that time had not informed a national policy. Now in January, we say they can't be vaccinated. Then the question is, what has changed? So then it requires a lot of engagement to address their fears, because they would have to entrust their life and the life of the unborn babies to your hands as you introduce this vaccine. But interestingly, looking at the data we had, you'd realize that although coverages are higher for urban women as compared to rural women, when it came to pregnant women vaccination, uptake in the rural community is much higher than the urban community. And you would ask why. It goes back to the approach. A rural woman is most likely to be offered a vaccine within her CHIP setting by a healthcare worker, a community health officer who she sees constantly, probably lives in the same community with her. So that issue of trust in that individual to give her something or do something to her that would not harm her and her baby is resolved or settled. So she has that confidence and trust in the system, in that individual offering her the vaccine, as opposed to the urban sector, where because of the huge numbers, we have various volunteers part of the vaccination team. Therefore, a pregnant woman will be most likely offered a vaccine by someone he or she doesn't know. So then that accounted for the very low coverages, because they kept on asking questions and they didn't know the people who wanted to give them something that would affect them and their babies. So programmatically, we had to now also look at engaging the midwives during the focused antenatal care to be the ones to convince the mothers, and then move the vaccines to the antenatal care settings, to the pregnancy school clinics, so that at that point, within their comfort zone, within people they trust, they will be more willing to take the vaccine. So consistently, data continuously helps us to review our plans and approaches, and then also informs the implementation process. And there's definitely no straight jacket approach. Constantly, data has to drive the entire approach.
Great. Thank you, Akuswa. So I'm going to take a few questions that have come in through the chat, and please put your questions in the chat. And I'm I'm going to put our two member state representatives on the spot on this one. There are a couple of questions about why this isn't happening. Why isn't WHA doing this? Why isn't this a requirement? Maybe you or from the U.S. and Australia, you can comment a little bit on that. So the question is, why is the WHO finding this challenge, and why can't it be a priority right from the start of a policy framework? Over to you. Sarah, do you want to go first?
Yeah, look, I can, and thank you. And it's a really, really important question, particularly when there are so many of us that have worked in this space for such a long time and know how critical it is. You know, I don't have a straightforward answer for you, because it falls in the space of one of those areas where those of us that know that this information is critical are here, and the decisions that are getting made in the fast-paced, moving moments of a pandemic and a crisis, as Akoso was just saying, is it really is being guided by a level of uncertainty. And I guess to be completely candid with you, a sense of needing to be very reactive to new information as it comes forward. And so sometimes the critical some of the critical things have got lost along the way. But that I would say that I think WHO has been doing a really important job at trying to support countries to look for sex disaggregated data, to encourage countries to report it, to use it. I mean, the guidance is there, but everybody is also very conscious that this is an experience that's affected everybody, and health systems have been under unparalleled levels of strain. And so the things that we think normally are just really easy are unbelievably complex. So that's what I would say. Jamille, you may have a better answer than I.
And Jamille, I'm going to add to you another question that's come into the chat, which is, could the lack of reporting of gender and sex disaggregated data be due to the ostrich effect, where there's a cognitive bias that causes people to avoid information they perceive as potentially unpleasant? So maybe you could add that into your response as well.
Thank you. So to the first question, I agree with what Sarah has shared, that there are important steps certainly that have been taken by WHO and Gavi and UNICEF and others. WHO has, for example, guidance on gender action planning in the immunization agenda, and support to countries doing this work. So I think that there's certainly space there to continue to beat that drum, to continue to make that ask. And even if it, I think there's a question of requirements and accountability around that data reporting requirements. But it's certainly important to continue to be asking for the data and continue to be sending that signal consistently that there is interest in this data. And then across the community, across the donor community, support for countries to address whatever gaps they have in being able to provide the data. So that what we talked about of making sure the central digital systems, digital data systems, or whatever the gaps may be, are in place, so that we have both a consistent demand signal from the WHO, and then consistent support to countries to help close any gaps they may have in being able to respond to that demand signal. So I think if we kind of keep together calling for both of those steps, that we'll see more progress on that front. On the idea of the is this are we not collecting this data because, you know, we don't want to see these potential disparities? You know, I think at the end of the day, right, the government's doing this work, the, you know, partners providing services, you know, this is, sorry, just to say, this is obviously, you know, a gap across all gender data. So, you know, coming back to the fact that we see these gaps, you know, in a lack of collection of sex disaggregated data around COVID-19 vaccination is consistent with gaps we see across data systems on other gender data measures or other people measures that don't collect sex disaggregated data. And I think there, you know, there is a piece of intent of understanding that these differences exist and that they matter. You know, understanding that that the people level data is not sufficient, and that in fact the experiences of men and women, girls and boys, individuals of diverse gender identities are not necessarily the same, and we need to ask that question to find that out, and then to be valuing, asking that question, to be valuing that our policies and programs are in fact reaching all different communities, and that will help us achieve our goals. If we're trying to reach, you know, 100% vaccination, or that we need this sex disaggregated data and data disaggregated by other measures as well to help us understand who's not being reached. We're not going to achieve our goal if we're not doing that. So I think it is kind of an appreciation that the baseline, just person level data is not going to give you the picture you need to achieve the policy program goals that you've set. And then an investment in value in ensuring that we truly are reaching the full population in that work.
Great. Thanks. And, you know, there's been a couple of questions that have come in to the chat, and maybe actually Fiona and Mira, get your reaction to these. So we talked about reaching the unreached and the importance of engaging communities and women. So the question is, what have we learned, and how can we build an engagement of women's groups and girl-led centered organizations into this process as we think about gendering programming? Mira, maybe we'll start with you.
Thank you. I don't have the whole answer, that's for sure, but I think one of the things that I've seen with different examples in the Indian context and elsewhere is that if we start from an understanding of where the gaps are likely to be, sometimes the change that it takes to bridge the gap is something that isn't that incredibly tough for us to figure out, and we can engage groups. So early on in the COVID-19 pandemic, my colleagues and I were involved in, it was an emergency response service where we used a digital approach to reach communities coupled with linking to community groups. And the innovation in what we did, I mean, it was innovative just to start it up, it was just an emergency response. But the innovation in what we did in particular was to say, if we want to make digital communication effective for people that are less literate in low literacy communities, let's use the simplest mechanisms possible that don't depend on having a smartphone and that don't depend on literacy. So audio capsules destined for the simplest phone possible. And let's link it up to someone who can deliver face-to-face communication on the ground thereafter. So we actually were able in a space of 100 days to mobilize, I think it was 29 civil society partners and reach 1.15 million people, which was really the power of grassroots community mobilization in general. So I think that there are ways to do things which are both high tech and low tech, but if we start from the problem and look at it, sometimes the appropriate solution is not the highest tech solution. So not the fancy app telling me where I am and having other people detect where I am. I'll stop there.
Fiona, thanks, Mira. Building on that, you know, you've been working across the Afro region. What have we learned about how we can build an engagement of women's groups and girl-led centered organizations into our efforts to vaccinate?
I think there's a great opportunity in gender mainstreaming into these planning processes and groups. We've seen when we were rolling out the HPV vaccine, for example, in a number of African countries, dealing with women's groups and girls' groups as the opinion leaders, as peer groups to talk to other girls, as the women to, because the women understand cervical cancer more than the men understand cervical cancer. We saw it's something that is very useful. It's very useful. However, we need to note that generally the education levels of women, the empowerment, the ability to make decisions, even when they come together, it's pockets in different societies in Africa. We have places where that worked very well. In Rwanda, for example, in Malawi, in Liberia, in countries like Ethiopia. But we have some countries where the communities are still so patriarchal, the societies are so entrenched in the cultural values that the empowerment and the ability of women to speak up even when you get into their groups becomes difficult. But indeed, we have seen it work. Most of our community health workers and volunteers are women who get out there to teach the rest, but also the peer-to-peer education is very important. And we know that once a woman speaks to another woman, it's easier done than when a man tries to sell something to a woman.
So we've already you've all given a number of thoughts about actually there are solutions to addressing gender gaps, gender programming, and just before I turn to Sarah to talk a little bit about that, I do have a question that has come up. Are any of you aware of efforts or can describe some best practice about reaching the transgender community? You know, this is an adult vaccine. For the first time, we really have a universal adult vaccine. Is there best practice? We looked at the data. Certainly, there are no data being reported on this. Only 2 countries are reporting data on gender distribution other than male and female. So can anybody bring us to best practice or? I'm afraid the answer is probably no, and not judging from anybody raising their hands at this point. And I think it's a great point. And we do have to walking the talk on thinking about gender as a little bit more diverse than sex. So thanks for that point. Sarah, as we start to think about towards solutions, can you point us in a direction, gender-related learnings from COVID vaccine that can inform either further COVID vaccine rollout or routine childhood vaccinations?
Thank you, Nina. And I mean, what an amazing conversation to be a part of. I think there's 2 points I'd like to make. And the first is, and we've talked about it a few times in different ways, but it's really when you're talking about recognizing that the pandemic and the way that immunization campaign has evolved is in the context of a range of other gendered inequalities. It sounds really simple to say, but actually it's quite profound because you just put Jamille and I on the spot, but when you're focusing very much on trying to understand a new disease, it's all about the science. And sometimes you forget about the social context. But actually, when you're talking about the campaign and getting the vaccine to people, it becomes fundamentally about the social context. So, and when you start talking about the social context, you inevitably end up needing to address gender in order to have an effective campaign. And so those sorts of gendered inequalities that we saw around the shadow pandemic and increased rates of gender-based violence, the she session of, differentiated sectors where, sectors dominated by women, lost work and at much higher rates than men. The increased rates of early child and forced marriage, the impacts of lockdowns on school education and girls' ability to return. I mean, these are all things that need to be taken into account when we're engaging in a community that's in a point of crisis. And the second thing, and I think this does speak to one of the points that was just made, is just how critical it is that when we are working at the point of preparing for delivery, that we, as well as engaging incredibly powerfully with our governments, is we engage with women's organisations and with community organisations who have got different points of ability to engage with community, and to get them to do the gender analysis that helps support the programming. And I'd like to give a couple of shout outs to two organisations based in the small, the Pacific Island country of Fiji, the Fiji Women's Rights Movement and Live and Learn. Fiji is a country that experienced 3 cyclones in 2020. Well, one in April 2020, one in December 2020, one at the start of 2021, and then COVID came. And so there had been multiple disasters, but it was the gender analysis that was done that really helped form a campaign around reaching communities that addressed some of the fundamental issues around how people wanted to get information and what sort of issues that they needed to have explored and explained to them around trust, particularly around the cost of being able to access services and travel, but also understanding the benefits. And I was really struck that while the majority of women that were surveyed, said that they trusted government sources as their main route of information, 74%, 73% were also using social media platforms that had had a really rich range of different credible information, and only just under 40% were even positive about having the vaccine at all. And I think the fact that those analyses were invested in with a range of different civil society organisations has actually been incredibly powerful, because now the country's got over 71% of the whole population is double vaccinated. So I think that was the second point. And the third thing is, and Fiona just mentioned it around HPV, is sort of stepping out of the space of delivery, but it's actually kind of stepping back and thinking, where are the spaces where in gender and immunisation we can use science and research and investment to keep pioneering on diseases that we know really affect women, like cervical cancer. And I have to say, as an Australian, I'm so proud that we played a role in the science around developing the HPV vaccine, and to see the news that just came out from WHO just in April that now you actually only need 1 dose and you can be you can be fully protected is just going to be so powerful. So I just wanted to make that point, as well as we need to look at understanding the multiplicity in society. We need to use gender analysis with civil society organisations to help us at the start of our campaigning. But 3, we need to just keep looking at the macro level and encourage the science to continue to work in the spaces that we know will make a difference to women's lives.
Great. Thank you, Sarah. Lots to think about. We extended this panel from 60 to 90 minutes, and I truly wish we'd extended it from 90 to 2 hours, because there is so much to talk about on the issue of gender and immunization. And as we think about what you've heard, I want to ask each of the panelists to reflect on if there's one thing that they could stop, one thing they could start, and one thing they would continue with regard to vaccines and immunization and gender, what would that be? So maybe Mira, I'll start with you. If there was one thing you could stop, start, and continue, what would that be?
I'm going to make it simple and just to stop and start. So I think what I would like to stop is individual biomedical approaches dominating our way of thinking all the time. So vaccines are amazing. I'm a vaccine junkie. It's all that I do. But vaccines, as Sarah pointed out, the science is one thing, delivery calls into question more complex things. And those are also things for which we have a lot of scientific knowledge and knowledge that comes from community groups, from policy interventions. And somehow we keep on forgetting about all the rest and focusing on the actual technology. We have a vaccine, as though the having of the vaccine is in itself enough. So the thing that I would like to stop is I would like to stop us from having that focus just on the technical, and to broaden our focus to the rest of what we do know. And so what would I like to start or to have continue? I would like to see very many more things like the UNU checklist, which ask us to think very carefully through the factors that we know from scientific research and from experience and policy innovations that we know are important for delivery and for equity, and to make those operational. So I would like to see far more of that, and I will pass on the honor of responding to the rest of the panel.
Great. Thank you. Sarah, I realize now I'll go backwards from my first teacher call-ons to the back. So that should give you a sense of where you are in the order. Sarah, over to you. Stop, start, continue.
Yeah, thank you. I would stop accepting data that's not disaggregated by sex. I would start working with women's rights organisations in the design of every vaccine campaign. And I would continue a rollout of HPV.
Great, thank you. Fiona.
Yeah, thank you. So for me, what would I want to see stop is seeing and treating women just as mothers and wives, as they just need to be seen as human beings who have an equal right to health and well-being and can make their own decisions regarding their own lives and health. Then what we need to start? The mainstreaming indeed of gender into the planning processes. It was mentioned here before that the policy at the policy making level, making it intentional that women are on the table, because they do understand what we understand what affects us. Previously I was telling people about COVID, and when we were quarantined and people severely quarantined, no one thought about women requiring, for example, sanitary towels, and that was never given because no one thought about it. So when women are on the table, they do make these decisions because they know. And I'm glad that the Immunization Agenda 2030 has put gender as a cross-cutting theme throughout immunization. Then what do we want to see continue? Addressing the operational and financial and implementation bottlenecks that affect women, empowering women at all opportunities with the information and the ability to continue and serve and engage communities and help more people get vaccinated.
Great, thank you. Jamille, stop, start, continue.
Thank you. So I agree with what many of my panelists have said. So just building on this in terms of stop, I would say stop assuming that the experience of and access to services of men, women, girls, boys, individuals of diverse gender identities is the same. These are different, and we need to recognize that. I would start making it standard practice that all of our person-level data is sex disaggregated, and continue to roll out digital data systems, so countries have the tools they need to collect this data. Continue to advocate for women's leadership and decision making. This was a point that fellow panelists raised of when all of the initial policymakers and the COVID response were nearly all men, that influenced the response that we had. So we need to make sure we have women at the decision-making tables, as well as consulting women, civil society, women's rights groups in all of the outreach and work that we do. Thank you.
Great, thank you, Jamille. And Akus, over to you. Stop, start, continue.
What we would want to stop would be to stop recording data in just on the superficial value, just looking at just male, female, but we need to go further to look at the gender disaggregated data across all levels. So there shouldn't be just one country specific or just 14 countries reporting globally, but there should be a system where every country is mandated to report so that we can analyze it much better on the global space. What I would want to continue is we want to continue to see more women, as everyone has said, in the agenda setting space. There's a statement, a saying in country, I'm not too sure where it's from, but it says that what's designed for the youth without the youth is against the youth. And I think that it will be good to apply it for women and all other genders, that what is for us, which need to be part of that process in implementing or deciding or planning it. And then that way we can advocate for it in the best way that would help us. So we'll continue to push to have more women in the development space, in the agenda setting space, and then not just women. Whenever what has to do with girls should be part of the entire process. Their perspective should be heard. What would want to continue is would want to complete and ensure that we invest in helping lower middle income countries have data management systems that they are able to, electronic data management systems that would help them analyze their data real time, so that locally, without any external support, they can use that data to make changes in their care processes. And that is very important. Implementing an electronic data system on the scale for the COVID-19 didn't come easy for us as a country, where you have internet challenges in places, inadequate laptops. So investing in the data comes from a process and it requires a lot of investment. We definitely will have data quality issues and other things, but it is a start. Having a reliable data system is a start to having disaggregated data by gender. So we would need to invest in that so that from the source, the data can be generated for us to be able to analyze effectively. Thank you.
Great. All right. Thanks so much. Well, fantastic panel. Thank you for this hour and a half, and back over to you, Pascale.
Great. Thank you so much. I'm sure you agree that this was an amazing group of panelists to raise these issues. I think the Stop, Start, Continue provides a really nice summary. I just want to stress a couple of points there. The issue, while it may not have been spoken about specifically, the issue of sex versus gender. That we do need we need the sex disaggregated data, but we need to also do gender-based disaggregation and gender-based analyses to be able to understand the power dynamics behind the problems that we see. Data collection, why is data collection not happening? Why are these gender issues not being mainstreamed? Who is accountable? Absolutely a question we need to keep interrogating, keep pushing those who hold the accountability to be accountable for it. A really important point I thought was also relates to the fact that vaccines as a preventive strategy forces us really to think about gender. It's not, there are decision processes and structural processes that lead from having a vaccine, which is for prevention, to actually obtaining it. And this makes a very important point why gender needs to be considered as part of this. I also really like the idea that we need to stop focusing solely on the technical and really think about what it requires to actually get vaccines to people. Power of community organizations, sharing best practice experiences, all absolutely critical. And I hope all messages that everybody in the audience is going to take to heart and be very much a part of our work going forward. I'd like to thank Nina, Akosia, Jamille, Fiona, Mira, and Sarah. Thank you so much for your time. 90 minutes of your time. I hope it was worth it. It certainly was for us. Tiffany, Anne, and Vidisha, we can't do this without you. Thank you very much. And for everybody, please look out for the next webinar on the 12th of May, which is with another one of our commissioners, Jessica Horn, in conversation with Latanya from the Global Fund for Women. And it's a really exciting discussion on feminist funding, feminist philanthropy, and how to make sure that our grassroots organizations are well funded to continue to do the wonderful work that they do, because they are making so much difference on the ground, which frankly we're not doing so well at within the traditional global health space. Have a lovely afternoon, evening. Thank you again for joining us, and we look forward to seeing you at our next webinar. Thank you again.